I hope you can hear me.
Yes, Professor, I can hear you.
Okay, let us start. Once again, I apologize for the late start. We have got a very big eye camp at the Harrow Eye Center, and so it's been occupying my mind a lot. So today we are talking about ocular and adnexial injuries. That is, injuries to the eye and the structures that surround the eye. The objectives of this lecture are, by the end of the lecture, you should be able to describe the different types of injuries to the eyes and surrounding structures. Should be able to describe situations where ocular and adnexial injuries tend to occur. Discuss ways of preventing ocular and adnexial injuries. Discuss investigations in ocular and adnexial injuries. Describe complications of ocular and adnexial injuries. And discuss management of ocular and adnexial injuries. Where do ocular and adnexial injuries tend to occur? Those of us living in Uganda at this time know that boda has taken on as the leading cause of accidents, which involve, and we eye people are also not spared, but also cars and bicycles tend to cause some injuries. Then the next place is the workplace. I guess you could say it's for the boarders and the motorcycle, sorry, the car drivers. The car is their work, or the road is their workplace. But other workplaces are things like places like grinding particles in workshops, when they are faulty machinery and things break, like for example, a machine might break, or someone's tying stuff on his bicycle, or border and the rubber band breaks. Then the industries, there are chemicals splashing into the eyes. The other common places at home, playing with sharp objects, children, and throwing stones, and situations of domestic violence. The other place is leisure and entertainment. These ones of late have decreased because of the places have been locked up, but they also tend to contribute a lot to injuries, which also affect the eyes. Then the battlefield, missiles, bullets, and bomb fragments. Thermal or radiation or chemical agents. Now, when we look at it by site that is injured, I can put the eyelids and lacrimal system, the eyeball or the globe, and then the orbit. An example of an eyelid injury. Eyelid injuries can present as periocular hematoma or black eye, consisting of a hematoma, which is a focal collection of blood, and or periocular ecchymosis, that is diffuse bruising, and edema, that is swelling. It is the most common blunt injury to the eyelid or forehead.
Now look at
Someone who is
Even
unmuted, please
that
mute yourself.
You can.
Please unmute. Please mute yourself. Then eye relaxation, the injury should be considered as a major injury. Just a moment. Let me look for this person who's making noise.
I think she just wants to do signatures by saying she accepts us. Like questions. I don't know.
Let me now try to come back to the class. About eyelid injuries, and we said that, I said that when you are handling an eyelid injury, always think about the globe and the orbit, because they could be injured together. Something like injuring the eyelid could penetrate into the orbit or into the eye. Then we should also look for orbital fractures, especially if the black eye is associated with subconjunctival hemorrhage without a visible posterior limit.
Professor, we got disconnected before you read there. Maybe you can go back because we had just started on the black eye. That's where.
Okay. We had already seen the types of eyelid injuries.
Yes, we have seen
that
that
picture.
Yes.
And we're talking
this
about
is where
the black
we are.
eye. It's you,
Yes.
you lost me.
Yeah. Yes, Doctor Professor.
So a black eye is when there is surrounding dark shadow around the eye due to collection of blood or due to bruising. And is the most common type of injury as far as the face and the eyes are concerned. Then there is lid laceration. And lid laceration or tear should be considered as a major injury. It may look small, but the management needs expert care, and also the fact that it may be accompanied by other injuries. any lid defect should be repaired by direct closure wherever possible, even under tension, since this affords the best functional and cosmetic results. Rule out other injuries, like I just said, trauma to the globe or the orbit. It is easier to examine the integrity of the globe before the lids become edematous. When you see someone has just been injured or within the last 24 hours, the tissues still have their natural appearance. But as you wait, the inflammation comes in and there's edema, it becomes very difficult to assess. When the eyelids, you look out for opto fractures, especially if there is a black eye associated with a subconjunctival hemorrhage without a visible posterior limit. That is, you can see there is blood under the conjunctiva, but you cannot see how far it reaches. It may actually be coming from the orbit. Then there is also basal skull fracture, which may give rise to characteristic bilateral ring hematomas around the eyes. When you see that there is that hematoma, think of the possibility of basal skull fracture. And this is usually a cause of optic nerve damage. The other injury you have to look out for is the canalicular or lacrimal lacerations. I hope you still remember what the canaliculus is. The tube that drains tears from the eye towards the nose and bringing the tears into the lacrimal sac, and then the sac sending the tears to the nose. In the management, when there is just periorbital edema or bruising, usually you observe and give the time here. You may apply cold compresses. If necessary, give some analgesics. Now, if there are superficial lacerations parallel the lid margin without gaping, this can be sutured with something like 6-0 silk, and the sutures can be removed after 5 days. Lid margin lacerations invariably gape and must therefore be very carefully sutured with perfect alignment to prevent notching. Lacerations with mild tissue loss, just sufficient to prevent direct primary closure, can usually be managed by performing a lateral cantholisis in order to increase lateral eyelid mobility. Having said this, is that if you are working in a situation where you're able to refer to an ophthalmologist or a plastic surgeon, lid lacerations involving lid margin and or tissue loss, this should be referred as soon as possible. Lacerations with extensive tissue loss may require major reconstructive procedures, and these are handled by an oculoplastic surgeon or by a general plastic surgeon. Canalicular lacerations should be repaired within 24 hours if possible. And part of the repair involves passing a silicone tube, like a Crawford tube, which is passed down the lacrimal system and tied in the nose, following which the suction is sutured. There are also what we know as monoca tube. This one is monocanalicular. It can be used even can be passed only in one of the canaliculus that is involved. The Crawford tube is bicanalicular in that it has got a piece of metal which you pass through the upper punctum and the canalicus and pass it through the nose, then also in the lower one, and then you tie the two ends, the two plastic ends together. The mini monocone, you just pass through whichever canalicus is involved. If there is a chromosomal injury, it should be explored through a skin incision and repaired, leaving a silicone tube again. Now, complications of lid injuries, it can be scarring, it can be disfiguring. If care is not taken in the repair, there can be misalignment of the lid margin and lid margin. It can lead into entropion, that is eyelid turned inwards, or ectropion with the eyelid margin turned outwards. There may be infection, and if the lacrimal drainage system has been affected, there may be tearing, and this might need DCR. DCR in the full is dacryocysto-rhinostomy. Either by mechanical or non-mechanical injuries. Mechanical injuries can be burn trauma or they can be perforating injuries. Mechanical trauma is an injury to any portion of the body from a blow, crush, cut, or penetrating wound. The complications of mechanical trauma are usually related to fracture, hemorrhage, and infection. Non-mechanical injuries include chemical injuries, thermal, electrical, and radiation injuries. They can also be a result of biological or chemical processes or change. This is a flow chart to help us understand injuries to the globe or the eyeball. The injuries to the globe can either be closed globe or open globe. Now, the open globe can be contusion when the eyelid is just kind of crushed, or it can be lamellar laceration when the eyeball is not completely torn, but partially, the wall is partially damaged. Then the open globe can be classified into a rupture or a laceration. And the laceration can be of two types. It can be just be an penetrating or perforating or intraocular foreign body. Now, the difference between penetrating and perforating is that the penetrating injury has got one wound on the eye, the entry wound. Whereas the perforating wound has got an entry wound and an exit wound, typically caused by either a missile, like a small particle that enters the eye and also goes through the eye and goes into the orbit, or a nail, a needle, a compass, which can pierce the eye and go right through it. That's called a perforating injury. Quite often you confuse perforating and penetrating. So this is a simple injury to the eye where there is only just subconjunctival hemorrhage. Whereas this one is a corneoscleral laceration. You can see here, the eye has been lacerated, and that black tissue showing through is uvea tissue, either the iris or the choroid or ciliary body is showing through. Here is a rather neglected injury at the limbus or near the limbus, where the iris prolapsed and was not given adequate attention, and it has been covered by epithelium. What you see as that pear-shaped bulge is the iris, which has been covered by epithelium. You see the surface is already smooth. Is that covered by epithelium or by fibrin? Fibrin can coat it, and you find that it's already smooth surface. We have just talked about these. Now, it is important to bear in mind when you're handling these injuries, these golden rules. Immediate treatment is directed at preventing further injury or vision loss. Then I've already mentioned that never think of the eye in isolation. And always compare both eyes. It might give you a hint if only one eye is involved. Then always record visual acuity, as it is important it has important medical legal implications. I've already said that many of the injuries are acquired in motor accidents or road accidents, and those are medical legal situations. You may be asked to fill police forms, and it is important to record visual acuity before the patient has started thinking about the legal implications. Because once they have started thinking about legal implications and they are thinking about possible compensation, they may not be able to tell you the truth as far as their visual acuity is concerned. Also, if you take the visual acuity and you get 6/6, it does not necessarily exclude a serious eye injury. For example, the eye may be lacerated, but not disorganized yet. So the retina can still perceive clearly when actually the globe wall has been broken into. Beware of unilateral red eye, as it is rarely just conjunctivitis. Always watch out or look out for deeper injuries. Also, if injury is self-evident, avoid further manipulation. It requires urgent ophthalmic consultation. If in doubt, always use X-ray or CT scan or MRI scan if available. Now, there's a question about MRI. If you're suspecting a metallic foreign body, don't subject the patient to MRI because it involves magnetic fields and they can cause vibration of the metallic particle and can cause serious damage within the body or within the eye. And accurate documentation cannot be overemphasized. Always document. As I said earlier on, some of these injuries have got medical legal implications. And if you are to go and give evidence, professional evidence, you need to have good records, especially as you may be requested long after your initial encounter with the patient. Right now, I have got an outstanding court case where I'm supposed to go and give evidence, but I've been postponing the case each time they have been inviting me. We have also talked about classification. Management. General principles of management include open globe injuries are managed depending on the type and extent. Penetrating injuries should be evaluated and treated immediately. And severe visual loss depends on material causing the injury, location of entry, and tissue involved and the extent of injury. Early diagnosis and initiation of appropriate treatment to the injured tissue improves prognosis and visual outcome. A suspected or obvious ruptured globe should be protected from any pressure or inadvertent contact with a rigid shield during transport. Eye patches are contraindicated. If you think someone has got an open wound injury, put on an eye shield without a pad. Because when you put on a pad, the pad will add more pressure onto the eye and may lead to extrusion of the eye contents. So if you don't have an already made eye shield, you can make one from a piece of cardboard, say like the cover of a notebook, cut it into a circle, make a line towards the center towards the center, then you make a cone, and then you tape the cone on the patient's face so that there's no direct pressure onto the eye. The recommended approach in the evaluation of potential globe rupture or penetration is to maintain a high index of suspicion of what is often an occult injury. High suspicion index. A careful and detailed ocular examination should be done. Then appropriate diagnostic studies are necessary. When CT scan is available, these days X-ray is not often needed in investigating eyelid or globe or orbital injuries. When an open globe injury has been confirmed, a few questions need to be addressed. One, does the wound require closure or is it self-sealing? Is an intraocular foreign body present? Are there signs of endophthalmitis? Lid lacerations. Look carefully for fat prolapse. Fat prolapse, lid margin involvement, and canalicular involvement. Then you can repair the lid, mind about lid margins. Now, when you're repairing eyelid wounds, attention needs to be, you need to pay particular attention to the type of suture that you use. Generally, 40 or 50 is the thickest suture that is acceptable to use on the eyelids. However, quite often we get patients who are referred to us after some first aid repair has been done, and find that people have used something like 20 nylon. far too thick for the eyelids. In that case, it might be better to arrange for urgent referral rather than attempting when you don't have this, the right materials to use. Then for corneal abrasions and intraocular foreign bodies, check for conjunctival foreign bodies and remove them. It may be necessary to irrigate. If there is dirt in the eye, you can irrigate it out. If you have fluorescein, you can stain and confirm where the abrasion is. Then you can put antibiotic ointment and pad the eye. Intraocular foreign bodies require immediate surgical removal and antibiotics. And antifungal cover in case of intraocular foreign bodies is in the case an intraocular foreign body is a vegetative matter. Now, the thing to emphasize is that in the common setting, most of these situations need to be referred. Penetrating lacerations, wound closure is mandatory. Again, this needs to be done in an eye unit. The primary aim of the surgery is to restore the anatomical integrity of the globe. The cornea should be repaired first, then the sclera is exposed and also repaired if there is a corneoscleral recession. In the presence of uveal prolapse, if it is not very badly damaged, you can reposition the iris tissue, prolapsed iris tissue. Avoid the excision of the prolapsed tissue unless it is necrotic. In the case of vitreous prolapse, perform vitrectomy with cellular sponges and scissors or with the vitrector machine. Antibiotics may be injected through the scleral laceration. If there is globe rupture, spelling of rupture, excuse me, it's supposed to be RIU, with all uveal tissues out, evisceration is the only option. Evisceration is the removal of an eye whereby the eye contents are scooped out and the sclera are closed, usually with an implant to restore some of the volume of the volume of the eye. Now, a contusion, when this pressure is exerted on the eye, and the injury may be due to, there may be contractile injuries. And these include, these are the contractile. The injury is sustained at the posterior segment of the eye. The injuring object hits the front, the pressure is injured. And one of them is commercial retinal. This one manifests as retinal edema. When you look into the eye, you find that the posterior surface of the globe looks whitish. And there is what is known as spot at the macula. The macula stands out as a red spot, or in our case, just as the dark area against the white background. There may be macular edema or macular holes, retinal tears. There may be vitreal hemorrhage or even retinal detachment. This is meant to illustrate commercial retinal. You can see that an area of para, then the macula stands out prominently. I think this was an African eye. if it were in a Caucasian, this one would be looking red because our books are written mainly by people of light color. Some of the descriptions are not necessarily applicable to the black race. I want to say that we should always be made aware of medical legal implications. So management can be either medical or surgical. Conservative management in case of vitreous hemorrhage. So if there's just vitreous hemorrhage, you can wait, or it can be done surgically and evacuated. Just a little bit about epidemiology. The rate of orbital involvement among all serious injuries is about 15%. The three most common types of orbital injuries are fracture, 75%, intraorbital foreign bodies, 24%, and orbital hemorrhage, 1%. Age, orbital injuries are most common in young people, that is 10 to age, and less common in extreme ages. This is because these are the most active or likely to be involving in risky activities. And then as regarding gender, orbital injuries the most common occur in the males. Again, because of the type of activity they tend to get involved in. I want to also talk of place of injury as regarding orbital injuries. It tend to occur mainly as a result of road traffic accidents, but can also occur at home, in recreation and sport, industrial premises, and public buildings. The cause of injury can be various blunt objects like fist, tennis ball, road accidents, gunshot, a fall, or sharp objects, nails or knives. In the interest of time, we are going to skip this classification of orbital injuries. You are going to get the notes so you go through it at your leisure. Assessment of a patient with orbital injury. Visual acuity, and look out for the presence or absence of ophthalmos or exopharmus on physical examination. Now, ophthalmos is when the eye sinks deep into the socket, and this usually implies that suggests that there has been an orbital wall fracture. When there's big injury to any of the orbital walls, then the orbital contents, they prolapse out of the orbit, say into sinuses, then the eye sinks back. Exopharmus is another word for proptosis, when the eyelid falls and is pushed outwards. This one usually occurs when there's orbital hemorrhage. Heart exophthalmometer is an instrument that is used to measure proptosis. Then you should also evaluate the movements of the extraocular muscles, especially when there has been a fracture of the floor of the orbit. The orbital contents may prolapse into the maxillary sinus, and the inferior rectus muscle may be trapped, and you may find that the patient is unable to rotate his eye upwards or to look up. Also, sensory examination in the distribution of the supra and infraoptical nerves. Supra and infraoptical nerves may give a clue that there has been a fracture. When you find that when you touch the cheek, that there is no sensation, or the place above the eye, means that the nerves first there may have been injured in the fracture. Also, when you palpate around the optical rims, you might be able to detect gross deformity, or you may feel crepitation or localized tenderness. Now, the crepitation is or what you call subcutaneous emphysema. Usually occurs when there has been fracture of an optical wall and is a communication between a sinus, a nasal sinus, a paranasal sinus, so that air from the paranasal sinus spreads under the tissues, in the tissues. And they usually are precipitated by someone blowing their nose, then the air enters the tissues. Further assessment may need auscultation for bruise, especially when there has been arteriovenous connection, like the case of carotid cavernous fistula. Also, it is important to examine the pupil reactions to light. They can give an indication whether there has been damage to the optic nerve or to any of the other nerves. And a slit type examination can be used to examine the anterior segment and even anterior segment with a special lens. Tonometry is measuring of intraocular pressure because many injuries are accompanied by high intraocular pressure. Then you can use those modalities when necessary: X-ray, CT scan, MRI, or ultrasound. The complications of opto injuries can include enophthalmos, that is the eye sinking in the orbit. There may be facial deformity if they are not, if there is no appropriate treatment and bones are not brought together again. There can be cerebral or ocular damage. Can be pneumocephalus, that is air into the skull, cranial cavity. There may be subperiosteal hematoma. There may be diplopia due to entrapment of the extraocular muscles. I've already talked about this. Or there may be hematoma, edema, contusion of the optical structures. All these may lead to impairment of ocular motility. Then in severe comminuted fractures, there may be pulsating exopharmus, which may occur as a delayed complication. There may be damage to the optic nerves with the decreased visual acuity. Sometimes you get a patient who was involved in a motor accident, did not sustain a visible wound, but loses vision, and you find that there is evidence of optic nerve damage. Usually that means there has been a fracture involving the optic canal. Carotid cavernous fistulas are quite common. Or there may be epistaxis due to avulsion of the anterior ethmoidal artery. There may be orbital hematoma and damage to the aquarium system. Now, opto injuries can occur as part of as one of multiple injuries. In that case, life-threatening injuries are taken care of as a priority. It is important first to keep the patient alive, then you can attend to the eyes and surrounding structures. Management depends on type and severity of the fractures. Now, mild and displaced fractures with no complications can be managed conservatively because bones always heal themselves. In the case of blowout fractures, that is fractures involving the walls, patients should be advised not to blow their nose. And antibiotics should always be given because when there's communication between the nose or the nasal sinuses, it means that actually is communication to the outside. And steroids may be used to reduce the edema. Surgical management is indicated when there is displacement of fragments or when there is herniation of orbital contents into sinuses or there is entrapment of extraocular muscles. This is best done within the first 2 weeks. It is very important if you are going to refer this to the specialist to do it quickly. Once the patient has been there for a month, it may be too late to do anything as far as reconstructing the orbit is concerned. Orbital reconstructed with the orbital implants to fill the gap in the orbital floor and all mini plates to join the bones together. The globe and aquarium system injuries are managed appropriately. I'm likely to forget something that I need to emphasize. When you're handling eyelid and orbital injuries and you think that surgical intervention is likely, please avoid giving non-steroidal anti-inflammatory drugs. I have noticed that quite commonly when patients arrive in the emergency ward, one of the medicines that are commonly given are injectable diclofenac. Now, if the patient is going to go for surgery, this can cause a lot of bleeding because non-steroidal anti-inflammatories have got some anticoagulant properties. So be careful when you are prescribing those. If you think the patient is likely to go for surgery fairly soon, please avoid them. And I have had some very nasty experiences trying to repair someone's wounds and you cannot control the hemorrhage. And especially in the eye, when you cannot see clearly, when you can't control the hemorrhage, you cannot oppose tissues accurately. I'm going to skip this and let you read it on your own. Orbital hemorrhage. This is a patient who has had retrobulbar hemorrhage. Intraocular foreign body. Please mute yourself. Intraorbital foreign bodies, they can be due to penetrating trauma or may have pain or decreased vision. The entry wound can be as apparent as an eyelid or conjunctival laceration. There may also be lid ecchymosis and lid edema, plus subconjunctival hemorrhage or ecchymosis. Proptosis and restricted ocular motility occur when there is a retrobulbar hemorrhage associated with penetrating trauma. Assessment for intraocular foreign bodies, a thorough ophthalmic examination must be done throughout penetration of the globe and optic nerve involvement. Imaging can be done plain X-rays may still be important, where the X-ray can show the presence of a foreign body and also give an idea of where it is in the body. I've already mentioned that MRI should be avoided if there's a possibility that a foreign body is ferromagnetic. This is a CT scan showing a big foreign body in the orbit. Oh, this is where we jumped from. Management. May involve culturing the entry wound, broad spectrum oral antibiotics, tetanus booster if necessary. If a foreign body is small and is considered to be inert, can be left alone. Surgical removal, if easily accessed, large or likely to lead to infection or chemical reaction. This is chemical injuries. Again, in the interest of time, I'm going to let you read it for yourselves. The setting, again, can be at home, in agriculture, in workplace, in industry, or a strong assault. I think of all these, the one you are most familiar with is assault, where strong acids are used as a form of revenge. You must be familiar with this. The examples of chemical injury. This shown by fluorescein staining is grading with the different injuries, helps in deciding on management. The only eye injury that requires emergency treatment without first taking a history and performing careful examination is when there has been a chemical splash into the eye. The immediate treatment involves copious irrigation with the nearest clean water that is available. If you happen to have saline, well and good, but otherwise tap water can still be used to wash out the chemical. It may be necessary to do double inversion of the upper lid so that the chemical trapped under the lid can also be washed out. Then you need to debride necrotic areas. Then continue with the medical treatment. Is some of the medical therapy. Eye surgery may be necessary to revascularize the limbus, restore limbal stem cell population, and reestablish the phonesis. The actual procedure, you will not be required to reach an ophthalmologists. Then there may be late surgery, which may be needed. some of the complications. You can see here that the eyelids are adherent to the eyeball. And in, because the cornea is scarred. Then there are thermal injuries caused by fire, hot fluids, or extremes of cold. These again, you're going to read for yourselves. Radiation injuries are not quite common here. Maybe ultraviolet radiation, which can come from arc welding, welders who work without protective goggles. Then ionizing radiation. This may occur, especially during radiotherapy. Take home. When you're in the general medical setup, it is important to involve the eye care team early. Quite often we see patients who have been in the hospital for 3 days before they are referred to us. And as we said earlier, early management, early intervention is very critical to the prognosis or the outcome of the treatment. Then remind you that eye and eyelid surgery is major surgery, even if the wound seems to be small. For example, there might be just a small wound near the medial end of the lower lid or the upper lid, which might appear very significant. But if it involves the canaliculus, that means automatically means that is a major case, because they need someone who has got magnification, who knows what to do to handle that. Beware of eyeball or orbital injuries accompanying eyelid injuries. So whenever you see an eyelid injury, always ask yourself if there might be something more serious. And always remember that there may be retained foreign bodies. Again, I need to emphasize this one. Watch out for corneal exposure, especially in a multiple injured patient. Sometimes the patient who is in coma, sometimes the eyes are ignored and they remain open and the cornea dries up. So even when you're trying to save life, still take care of the eyes. And then in repairing, remember to use fine sutures. And as I've said, 4-0 is the biggest you should use on the eyelids. Preferably 6-0 and 5-0. But if you don't, the other thing I need to emphasize is that when someone has